certified professional in healthcare quality. He is also a certified professional in Lean Six Sigma Black Belt, and he's a certified professional in key performance indicator as well. Currently, Dr. Irfan Bacha is working as a quality and safety manager in Qasim National Hospital's Kingdom of Saudi Arabia. So we'll start now. Dr. Irfan, over to you.
Thank you very much. Thank you very much, Dr. Saad, for having this presentation, and thanks for having me. I hope we can go ahead today, actually, because the topics that are so rich. I hope that we can cover. But I will be talking about safety culture, or just culture, that how we can develop safety culture in any organization. The second will be risk management, and with some examples. And the third topic that we will go through, that's staff development. So let's start with pursuing a safety culture, systems, and professional accountability. Can I carry on?
Yes, please do carry on.
Thank you. I believe the slides are not changing. Okay. Okay, so objectives of the session will be the role of safety culture as a component of safe and effective care. And the second is to know about the levels and components of safety culture. Then how we can measure and interpret the safety culture. Then explain the concepts of just culture and its impact on organizational culture, and application of techniques for implementing a just culture or a safety culture. Okay. So let's start with the definition. A culture is the way we do things around here. Shared values and beliefs that interact with the system structure to produce behavioral norms. So if we talk about a culture in a layman language, culture is what? It is just the way we dress up, the way we communicate, the way our living style. And these things come from where? These things are called behavior. Where it comes from, these are deep-rooted in values and beliefs, which cannot be seen but can be assumed, measured through behaviors. On the right-hand side, you can see that we have depicted iceberg. Will you control the voices side? Okay, thank you. So on the right-hand side, you can see an iceberg that we have. It is identical that how we can elaborate the culture. One part that what we can see, that what people see, and the other that is what is hidden. So the part that can be seen by the people at a given moment, what we call it as behavior, or we call it ultimate. But what people cannot see at a given moment, these are values and beliefs. These are deep-rooted, and the behavior, what the people show in any organization, or how they behave, how they work, it comes from the deep-rooted values and beliefs in any organization. It is just similar to a hidden curriculum, where the normal day-to-day practices in a work unit that often undermines formal education and organizational policies. So have you heard about safety culture before, or a safety climate? Anyone of you? Anyone can speak or can write. I just want to hear from the participants who have heard about, who have read about safety culture or a safety climate, or what is the difference between two? If anyone want to talk about, so I will just give 1 to 2 minutes, otherwise I have to continue. Okay, nobody wants to talk. A safety culture, what we call, or what we can see at a given moment, and we call it as a behavior. This term was used after the Chernobyl disaster, which happened in 1986 in US. And the safety culture is described as the personality of an organization, as it is a shared value of safety. While the safety climate, we call it as mood of an organization, which is based on what workers experience at a specific time. It is actually a snapshot of safety at one point in a time. Let me just ask you one thing. How will you know, or how will somebody know that he or she is working with an organization where there's safety culture, where there is a safety or just culture? Let me see the chat. Maybe somebody is writing. So, okay. Shall I repeat my question?
So may I speak?
Is that how will you know that where you work, you have a safety culture environment, or you have a safety culture in the organization you work with?
Sir, personally speaking, I think I would recognize that organization as having a safety culture in their workplace if my opinions and my pointing out of errors were appreciated rather than depreciated.
Exactly. That's great. Anybody else? Okay, so let me talk about it. If the staff exhibits positive safety behavior, for example, nowadays following COVID protocols without the staff being asked. So the staff is following COVID protocol that's exhibiting or showing positive safety behaviors. If the staff report events or incidents freely without fear of reprisal, the staff, they don't fear that if they report any event, so they will be attacked by anyone, the one against whom he is reporting, or against the department who is reporting, or maybe from the colleagues, okay? If the staff discuss safety matters openly, if the events are systematically analyzed for flaws in the system, not in persons, or if a feedback is provided for a purpose of learning. So these are some examples that where you work, you can just have a snapshot of the organization where you work with, that whether you have a culture of safety or not. Yes, an overall workplace culture that fosters positive relationship and outcomes, that's great. Okay, so go now, as we're talking about the healthcare, so let's talk about patient safety culture. It is an integrated pattern of individual and behavior based upon shared beliefs and values that seeks to minimize patient harm that may result from care delivery processes. Okay. Have you heard about this? Culture eats process for lunch. Some people call it culture eats strategy for breakfast or in breakfast. Have you heard about it? So if not, this idiom, if you have strong processes or culture, which is well written on paper, but you don't have the right culture in place, so those processes or those strategies won't work. So it is the culture of an organization which matters, not the processes, neither the strategies you develop. Okay. Key beliefs in a safety culture. There are 4 beliefs in a positive safety culture that you can see. One of those is processes are designed to prevent failures. And number 2 is that staff, they detect mistakes, they detect errors, they detect events, and we and the staff learn from those errors being reported. The 3rd is a just culture. And the 4th one, that the staff work in teamwork. Now, why do we measure a safety culture? What is the role of patient safety culture? Why everybody is talking about patient safety culture? We have to measure it, we have to analyze it, we have to improve it, we have to develop it. What is the purpose? Now, I have put two screenshots. The first one, you can see there is a negative correlation. One is showing negative correlation and showing a positive correlation. Like you can see over here, hospital survey and patient safety events. You can see over here the higher hospital survey and patient safety score are associated with fewer adverse events. It is having a negative relation. If you can see from the right-hand side, once there is an 80% or it is 75, between 75 and 80%, you can see the scoring and average composite. So here, the events, the patient safety events are less. As much the scoring is reducing up to 45 or 40. So on the y-axis, you can see that the safety events are increasing. So there's a negative correlation between the safety culture and the patient safety events. Here you can see a positive correlation. Again, if you have in your organization, if you have a positive patient safety culture or a just culture, so you can see that the behaviors and attitude of hospital employees can directly affect the pain, discomfort, health, and recovery of patients. It is on a scatter plot that's been plotted. So there is a positive relation. What we can say that as the staff satisfaction is increasing, so the patient outcome is also increasing. This is what we call it as a positive correlation. And this is what is measured by hospital survey and patient safety. The next, we talk about level of organization culture. You might have heard from in different organizations that they are writing suited plan, well-crafted plan, but they don't actually practice it. So something that you just write on papers, something that you desire for, something that you aspire, and the other thing that you have to show practically. So if you can see over here, the three levels: underlying assumptions, beliefs and values, and behaviors. Now the desired behavior could be what? Like around to assess catheter appropriateness. For example, a hospital or a unit is writing, they are having a safety plan or infection control plan, that a daily basis rounds will be conducted to prevent catheter associated infections or to see catheters being used, okay? The observed behavior that staff do not participate in the rounds. The next what we talk about the values, we believe different hospitals, they have different values. For example, teamwork could be one of the value, but what you observe that people work in autonomy, people want autonomy, they don't work in teams. They do write, if you see a hospital vision, mission and values, so it will be written teamwork, but people never practice it, or people seldom practice it, maybe not in every organization. Underlying assumptions like safety is a system property, but practically once we observe, so are the staff observe it as a result of individual competence, not as a system property. So can you just see the chat as well? So if there is any question at the time, so you can we can discuss the questions.
Yes, sir, I'm continuously looking at it. Let you know if
okay, components of safety culture. James Reason, he put a culture of any organization into 5 components. The first is informed, then reporting, then just, then flexible, and then learning. I have skipped the informed and I have put another that is HRO, high reliable organizations. And these are the examples like aviations and atomic energy. So these are what we call high reliable organizations. And now even the healthcare, the hospitals, principles to become HRO. Like one of the examples is King Faisal Specialist Hospital in Riyadh. They are working with different organizations to follow their principles to become an HRO in a healthcare. So what we're talking about, what we are saying that components of a safety culture is, first is a reporting culture. So what does it mean? The reporting culture, a safe organization is dependent on the willingness of frontline workers to report their errors and near misses. People, they report, or the frontliners or the staff, they report any event or incidents or accidents or errors, they report openly. This is what we call a reporting culture. And this can be measured later on once we come to the hospital survey and patient safety culture, so we can see that how we can assess that at what level of reporting our organization is. The second level is a just culture. So just culture is nothing, it is just about that the management support and reward reporting rather to punish the people. And the third is a flexible organization. We talk about that hierarchical levels relaxes when safety information is exchanged. So the purpose is valued, not the chairs or the positions. So if you're talking in front of a manager and the manager is just authoritative, or in front of a consultant or a physician or whoever, so in a set or flexible organization, the positions at those hierarchical levels, that doesn't matter. What matters is what you're talking about. Then is a learning culture. In a learning culture where reports are analyzed and appropriate changes are implemented. This is what we talk. This is how we say that the organization where we're working with, that whenever you report something, so they systematically categorize it, they assess it, and then take actions based on what lesson being learned. So this is what we call learning organization. And the last one is high reliable organization. Okay, so these.
We have a question here.
Sorry.
We have a question here. Sorry to interrupt you.
Yes, please.
Yeah, Osama Said wants to ask, how does culture affect patient safety?
How does
culture affect patient safety?
Okay, as we talked in the beginning, culture is what? The behavior and norms. So what you do, what actually you do, how you show your behavior, how you act in any organization. So this is what is affecting. If you, for example, let's say just culture. Start from the just culture. If you are reporting something, an event you reported, once you, for example, a medication error that you observed and you report, and the next day your colleagues or even the co-workers, whether they are nurses, physicians, or even your manager, instead of appreciating that what you report and you got a warning letter, or you got a verbal warning, or you got whatever that is, somebody is asking, why did you report such a silly medication error? This has nothing to do with the patient safety or something, whatever you heard about, okay? Or even your colleagues, your co-workers, that's what you're reporting. Do you think that it will add any value to you or to the patient? So negative comments will do what? At the end, what you will do? I want to listen from the one who questioned, what will be her or his behavior?
Sama, can you please answer the question?
Let me say again, will you report again such medication error? If there is a negative feedback to what you report, I think
calling out to Sama Said.
No.
So I think he's having some connectivity issues.
No worries. But of course, if you have a negative feedback, this is just one example. If you have negative feedback to what you report, of course, you will never report again. So if you don't report errors, who will be affected? Of course, the patients. So this is how you relate a culture to patient safety. This is just one example that is from establishing just culture. I hope the answer is clear. If there is any questions, so please raise.
Yes,
otherwise,
thank you so much, Dr. Irfan. I think we should move on now.
Okay. Improving safety culture. Now, HROs engage in continuous improvement. And once I say HROs, high reliable organizations, they continuously improve themselves. And there is a famous saying that we cannot change what we do not measure. So you have to measure first before you come to change something. So what you have to do, measure beliefs and behaviors. Then if you cannot measure, what you are going to improve? So you have to measure the beliefs and behavior. We are saying culture and culture and culture. How we know that where we are? So if we don't know where we are, how we are going to improve ourselves? So we have to measure the culture first. Culture is what? The beliefs and behaviors. Then we have to put an action plan for the weak points. After that, we have to implement the practices for what we planned. And then again, measure the beliefs and behavior, then again, action plan, and then still again, continue improvement practices. So this is continuously improve your culture, and then put an action plan, and then implement practices to improve the culture. Okay, who will be putting a poll? What is the influencing factor on management style for an organization destined to change? Technology, size, culture, competition. Sorry.
I have launched the poll.
Okay. Sorry.
By far, we've got a 90%, a 91%
Yeah, of course, the correct answer.
inclination towards culture. The rest of the 9%
there is
towards
one
size
answer
of the
that is
company.
size technology. It has nothing to do with management style for an organization that is resistant to change. So the management style that we had to influence a resistance, what we call it culture. Culture resistance comes from where? Not from the size, not from technology, not from competition. It comes from culture. So what you have to change? The culture of an organization. Of course, not a technology, neither the size. Whether an organization is small or large, whether you have up-to-date technology, sophisticated or not. The resistance comes from where? From the people. From what? The beliefs and behavior they have embodied. So this is what we call culture. And I think 87% of the audience, they have picked a correct answer. Thank you. Can you end the poll?
Yes, sir. The poll is ended. Now we can carry on.
Because still I can see on my desk. Oh, okay. Next, a nurse on a medical surgical unit does not work out medication administration while caring for one of her patients. What should her supervisor do? Ask staff if there are adequate scanners to meet their needs, counsel the nurse on the importance of following the policy, request that the pharmacy run a report of the barcode medication administration rates of the unit, ask the nurse what was occurring at the time and why she chose to bypass the policy. That's great.
Stefan, by far we've got a 62% inclination towards the last option where we asked the nurse what was doing.
So there is counsel the nurse on the importance of policy. Okay. I have seen that 47% went with counsel the nurse. Do you think counseling will work?
No, I don't think counseling would work if you do not know the root cause of the problem first.
Exactly. So where we can see the root causes, ask the nurse what was occurring at the time and why she chose to bypass the policy. Maybe she knew already about the policy. So the question is not only that maybe she or he, whether she or he knew about the policy or not. Maybe she already know about the policy, but the thing is there could be other reasons, systemic, what we call system flaws and system reasons, not individual, that resulted in something that she bypassed and the policy. So this is what we have. The appropriate answer is ask the nurse what was occurring at the time and why she chose to bypass the policy. So once you know the reasons, if she's saying the policy is not clear, okay, that could be something else then. But if she said the policy is very clear, but I was in rush, I was having another patient, I was alone, I was overwhelmed, so there could be multiple reasons, okay? So we have to go with the best option, that is answer D. Can we move to the next?
Yes, sir, please.
Okay, I have put those questions in the beginning, but I know these are quite familiar and are easy. That's why I put before rather at the end of the session. So the next is a known barrier to patient safety is staff not speaking up when they are concerned or if they see safety violations. So the questions, there was one question that how we can say that culture is affecting patient safety. So if you are not speaking, so this is where you will end. When they are concerned or if they see safety violations, you would help foster a culture that supports speaking up by what? You have the options A, B, C, and D. If there is anything unclear in the option, I will elaborate. Otherwise, I'm waiting for the answers. Using culture of safety data to assist low performing department. Okay, so 43% are going with option B and 56% are going with option D. Okay, look at the question again. A known barrier to patient safety is the staff not speaking up, not the management. Staff not speaking up when they are concerned or if they see safety violations. You would help foster a culture that supports speaking up by what? Using culture of safety data to assist low-performing departments with defining strategies for improvement. This is the best answer. Re-educating management on the use of principles, of course, it will help, it will work. But what we have to do, measure the culture by what? By hospital survey and patient safety culture. And then low-performing departments, what you have to do, use strategies for improvement. So the best answer is B. Okay. Can we carry on?
Yes, sir.
Okay. Next is, okay, we're talking about culture and how to improve the culture, and we should measure the culture for improvement. Okay, how to measure the culture? The next question is how to measure the culture. So how do we measure? There are two ways, qualitative and quantitative. Qualitative, you can use focus groups, small groups, structured groups that you can develop and you can assess the organizational culture. Structured interviews, observations. Quantitative survey, this is use best tool for your setting, whatever tool you can, the best tool is Hrq for Agency of Health Research and Quality, that they have developed a tool to measure the safety culture of any organization. So the goals of assessment, that's goals of culture assessment. What are the goals? Identify areas of culture in need of improvement. Why we are doing this? To identify the areas where they need to improve their culture, identify impairments in organizational learning, increase awareness of patient safety concepts, evaluate effectiveness of patient safety interventions, conduct internal and external benchmarking, meet regulatory requirements, identify gaps between beliefs and observed behavior within subcultures and microcultures. So these are the goals of having culture assessment. Okay, when and how to do it? Baseline prior to patient safety intervention. And then it could be done either annually or every 2 years. Sorry, it's month, it is yearly. You cannot conduct like every 12 to month, it is 1 year. So either annually, once in a 2 years interval to monitor the change over time. So in case A, because it is mandated by CPHQ that organizations should have measured their culture annually. So it is mandatory over here that we do measure our culture every year. Okay. So this is the tool that most of the hospitals are using, Hrq Tool. This is adopted from the Agency for Healthcare Research and Quality. The link is provided, anybody can Google it. This survey is having 42 items categorized in 12 composites. 9 dimensions measure the culture at department or unit level, while 3 dimensions measure the culture at hospital level. 2 additional outcome measures at department or unit level, that is for patient safety. And then at the end, you will. So how to do? Some hospitals, they do it on paper base. You can do it on paper base, while the other hospitals, they do it electronic. What we do in our hospital, that we provide the link on SurveyMonkey to all hospital staff. We share the link through either WhatsApp or through emails, and the staff, whoever they respond, so we automatically, we on the time, spontaneously we receive the feedback. So on a SurveyMonkey, if you can develop any link internally in your organization, or you can just take the services of SurveyMonkey, or even you can do it manually. Okay, these are the composites of the hospital survey and patient safety culture. As we mentioned, that there are 12 composites, so I'm not going to describe them. Anybody can Google and just go and check about it. Okay, the most important is, okay, now you conduct a hospital survey and patient safety culture. How to interpret the aggregate results. This is very important. How to display the results, and then how to have improvement plan. You need to have an action plan. So this is the critical part of the hospital survey and patient safety culture. Many hospitals, they conduct a culture assessment, but they don't interpret their data well, and they don't put action plan to improve their performance. So interpretation is reasons, components. What is reasons? GAMS reasons, components of safety culture. So we talk about the GAMS reasons, components, that whether is what we call informed, whether we call it a just culture, or we call it a learning culture, so or reporting culture. Then identify unit-wise areas in need of improvement, conduct external and internal benchmarking, understand reverse worded items. What does it mean? I will just, in the next slide, I will explain it. Identify beliefs and behavior in composites. For GAMS reasons, components, you can see a reporting culture, that a safe organization is dependent on the willingness of frontliners to report their errors and near misses. So now, how can you know, I'm sorry, how from the survey, how will you know that at what level of reporting your culture is? So these questions will be used in the survey: frequency of events reported or number of events reported. So these questions will tell you where your organization really resides in terms of reporting. The next will be just culture. So non-punitive response to errors. There will be some questions which will be talking about non-punitive response to errors. This will tell you that how strong your just culture is. And similarly, flexible culture, the teamwork within units, staffing, communication openness, teamwork across the units, hospital handoffs. These questions will measure the flexibility of your organizational culture. And the learning culture, the last one, that is hospital management support, manager actions, feedback and communications, organizational learning, or all perceptions, and patient safety grading. Okay. Then unit-wide areas which may need improvement. So you can have a benchmark for them below state or national average. Like in case, as I mentioned, that the patient safety, Saudi patient safety, we have a Saudi patient safety body. So what they do that they provide a link to the hospitals, and the hospital conduct the survey, and then they do benchmarking for the hospital. So you have to meet at least the minimum level of on a national level. Less than 75% positive or large gap between beliefs and behaviors. This is not something mandatory. You can, for example, you can just say that if you reach in every level to a 50%, so you will be happy with, you can have just a 50% as a benchmark. External benchmarking. So benchmarking, you compare your performance to somebody else. So if it is another hospital, so what we call external benchmarking. If it is internally, you compare one department to another, one unit to another, or even within nursing department, for example, medical ICU to surgical ICU, neonatal ICU to adult ICU. So this is what we call internal benchmarking. Reverse worded items. In the survey, you will see some questions will be marked as R. Whenever there is R written, the word R means that there are reverse worded items. And score should be reported in % positive. The percentage of responses rated 4 or 5 should be for agree, strongly agree, most of the time or always. So if a survey, if an employee opted like an agree or strongly agree, so you give it a score of 4. If it is most of the time or always, so you give it a score of 5. But if it is disagree or strongly disagree, so you give it a score of 1. When it is rarely or never, so you give it a score of 2 for reverse worded items only. Why you had to do? Because you had to measure the positivity, not the negativity. So positive is positive for patient safety. Higher score is better. We work, like for example, we work in crisis mode, trying to do too much, too quickly. This is what? This will measure negativity or positivity. I want to hear from the participants. What do you think? There is one question. We work in crisis mode, trying to do too much, too quickly.
Can you please elaborate the question a bit more?
Okay, now see, for example, we work in crisis mode. Simple. This is a question. We work in crisis mode. Always, whenever we are working in a patient pharmacy, it looks like we are in crisis. So when you measure this, and everybody is saying that yes, always, what they are saying strongly agree, or most of the time, or always. So what does it mean? What will it indicate? That you have a good culture, you have safety culture, or you don't have a safety culture?
I think working in a crisis mode where you have too much of a burden on yourself.
So we shouldn't be in crisis mode, right? Yes. To ensure patient safety, we shouldn't be in crisis mode. Everything should be in order. So once everybody is saying that, if they say strongly agree, if the question is we work in crisis mode and they say agree, so where we end up, we don't have a just culture, we don't have a safety culture. But once they say that disagree or strongly disagree, so this will have what? This will have a positive response. We don't work in crisis mode. They don't agree. Okay. Now over here, reporting culture, you can measure how you can measure with these questions. As I said, a reporting culture that staff report every event openly. So there are 3 questions that you can measure the reporting culture with. Like, for example, when a mistake is made but is caught and corrected before affecting the patient, how often it is reported. Then the next 2 questions you can see also. When a mistake is made that could harm the patient but does not, how often is this reported? So the first, they are saying 60%, then 68%, then 70%. So what do you think? If, for example, an organization whose benchmark is like for reporting, we are saying that our benchmark is 75% positive. So we are meeting the target or not?
No, sir, not really.
Of course not. We should be positive enough. If, for example, if your benchmark is 50, so you're meeting the target. But if it is not, and what we have to do, how we have to set the benchmark, for example, you are here and 70. So at least the first 2 questions you will drag to 70 or to 75%. This is what the organization should do. So with this, how can you see the culture, reporting culture in your organization with only these 3 questions? If you just want to measure a reporting culture in your organization, nothing else, only a reporting culture, you can use these 3 questions and you can see that at what level your organization is, how the staff feels safe to report any event. Okay, and then you have to action plan, of course. Every survey should be followed by an action plan. What like successful reporting system should be, there should be non-punitive culture, confidential reporting, independent reporting, not like that if you report any OVR or occurrence variance or medication error, so it should go to a supervisor and then it should pass by a manager and maybe he filter. So there should be independent reporting rather than such hierarchical positions. Expert analysis, then timely evaluation and reporting, system-oriented and responsive. So these are the actions plan, the action planning for the reporting culture. The next is that we measure the just culture with these 3 questions. Staff feels like their mistakes are held against them. The next question is, when an event is reported, it feels like the person is being written up, not the problem. We don't dig the problem, but we just question the humans, the staff, whether nursing, physicians, paramedics, pharmacists, or whoever. Staff worry that mistakes they make are kept in their personal file. And the response level is 30%, 36%, and 9%. Is it better to have like a 30% response to a staff feel like their mistakes are held against them? Does it show a positive culture?
No, sir, that would actually indicate some kind of a prejudice amongst the staff.
Yeah, of course. There is something wrong in the culture. Of course, they don't have a just culture. They, every time, whoever is reporting, so then negatively, they are giving him or her a negative feedback. That's why they're saying that we don't feel, staff feel like the mistakes are held against them. So 70% are thinking that no, yes, their mistakes are held against them. So, but 30% are saying no. So it doesn't show a just culture. And it should be, again, followed by an action plan. Action plan should be like understand human error, human factors, that is active errors, latent error, just culture and behavior, that is conduct a human error, negligence, or reckless. So how you have to treat them, we will be discussing those behaviors in further slides. Unsafe act algorithm and disruptive behavior and policy standards. So this is what you have to do after you evaluate your culture. Similarly, for flexible culture, I'm not going to detail them. You can see for flexible culture that we can measure the flexible culture by teamwork within units. Another is communication openness, handoffs and transitions, and this will be the action plan. If you have heard about team steps, that is team strategies and tools to enhance performance and patient safety. So you will find all those tools which can be used in action plan, which can be used in establishing action plan for flexible culture development. And this is a learning culture that is supervise and manage expectations, feedback and communication about errors. If you are not getting feedback, what you have reported, so automatically what will help that you will stop reporting such errors. So we should, how we learn from the errors, from reporting errors, that we should receive a feedback. What actions has been taken by the QIPS or by the risk management department? Due to time constraint, I will just go fast. Okay, next is, you heard in the presentation, we talking about just culture, safety culture, just culture. So what is just culture? Dr. Lucian Leib, he is a guru of modern patient safety. He said that the single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. And here's again James Reason. In 1997, he knew about that we should end up somewhere as in a just culture. Rather, we can say that not to blame individual for everything. We should have a balance between system and human errors, or system and human flaws. So we cannot just do one thing, that for every error or for every event, we are saying that the system is stupid. The system, once I talk about system, I don't mean software. Please understand, the system is the behaviors, the norms, the culture, the management support, the policies and procedure, the teamwork, the unity, all this what we call system, okay? So if we blaming the system for everything, this is what we call stupid approach, the system stupid approach. So you cannot end up for every error over here. You have to have accountability as well. Otherwise, the staff will think that everything, the quality and patient safety department or the risk management department or even the administration, they're putting everything on system. So khalas, whatever you can do, any error, it will be on the system, rather to have accountability. Once we don't have accountability, so it's human nature that they don't care. But of course, it's a nature, human, we don't mind it. So we should have a balance between human errors and the system. And this is what we call a just culture. Like for example, over here, there is an example that typical hand hygiene rates in 1999, it was 10 to 30%. Over last decade, tremendous push to improve where transparency and social pressures and more. Many hospitals now are stuck at what, 60 to 70%. Is it a system problem? Is it an education or a dispenser that we, all hospitals, they're giving training, education, and dispensers are even every 3 feet that you will find dispensers, or at least in every area you will find such dispensers. So is it still a system problem to have such low, what we call that compliance, that is 60 to 70%? To me, of course, it's not, because everything is available. People are being trained. So what is the problem in the system? Of course, it's not a system problem. It is a human behavior. And this is what we have to, how we can solve the human behavior, or how we can work on the human behavior. It will be discussed now in further slides. So just culture is about creating an open, fair, and just culture where the staff can openly report any events, they can discuss the events, creating a learning culture, whatever events are being reported. So this should be evaluated, and then feedback must be given for a learning purpose, designing safe system, and at the end, manage behavioral choices. What behaviors could be? Like breaches. Okay. What we can expect from humans once we talk about the human errors, or the human involvement or the human factor. So we talk about like human errors, at risk behavior, and reckless behavior. Okay, so human error is what? Inadvertent action, inadvertently doing other than what should have been done. Slip, lapse, or mistakes are the examples. At risk behavior is behavioral choices that increase risk where risk is not recognized or is mistakenly believed justified. While reckless behavior is behavioral choice to consciously disregard a substantial and unjustifiable risk. Let me give you examples. For example, you're driving home. You are done with your duty and you are going home now. On a stop sign, that time you had a phone call from your friend, from a spouse, from parents, from whoever. And that time you did not look at the stop sign and you just drive through. When you reach home, you realize that you have a penalty. You received a text message that you did not stop on a stop sign. So that time you realize that you did not stop at a stop sign. This is what we call human error. This could be due to distraction, this could be overwhelming, or this could be, like you can see on the right hand side, that the gentleman is taking a coffee and he's listening a phone call and he's driving through. So this could be, if he's consciously doing this, so this is not a human error. But if he did not notice what he's doing, so this is what we call a human error. The next is risk behavior, at risk behavior. Now, again, you are driving and the speed limit is, let's say, 70 kilometers per hour. And meanwhile, you are late and you just keeping a car at 70, 65, 70 to reach office on time. Meanwhile, you are 75, the police just stopped you, or there was a camera that captured you, that you were exceeding the speed. So this is what you are justifying the risk, but it is a behavioral choice. And this is what we call it at risk behavior. The third one, again, let's say you are driving the same car and you are late. But what you're doing, you are changing the lane hazardously, haphazardly. So you are going to the right and left and right and left, and knowing that there is too rush on the road. So this is what we call reckless behavior. This is a behavioral choice that you consciously disregard a substantial and unjustifiable risk. You cannot justify the risk of changing the lanes haphazardly. Okay, now I want to hear from you. What is this? A human error, at risk behavior, or a reckless behavior? I can't open the chat side. If you can see, or if you can allow them to speak, I want to hear from them. What is this? If those three behaviors are clear to them, so they should be able to answer, what could be this behavior?
Sir, we have a response in chat box in favor of the at-risk behavior.
This is reckless
I
behavior.
think the previous slide.
This one?
Yeah.
Okay, now we don't know how he was driving. If he was changing the lane haphazardly, so of course this is reckless behavior, but we don't see also rush on the road. So to me, it looks like at risk behavior, that the speed limit is 25, maybe he was speeding at 38, maybe 35. So looks like, because we don't have a complete picture, but looks like this is at risk behavior, rather a reckless behavior. This one is what? No answer. Don't you think it's a human error? Not from the baby, from the mother or the father. Maybe she or he did not notice that the baby is having, the child is having a marker, and this is where she will end up with. So this could be a human error. But if you have noticed, if it was a conscious disregard of a justifiable harm, so this is what we call then, it could be at-risk behavior. But this is what?
So this could be classified as reckless behavior because there is a quantifiable risk is present there.
Of course, we cannot justify the risk.
The risk being taken by the child.
Nobody can justify this risk. Having a crocodile, of course, who will justify this risk? So this is what? At-risk, reckless behavior. And drifting, again, it is also reckless behavior. So what you have to do, how you have to act once you have human errors, at-risk behavior or reckless behavior. For human errors, you have to console who was involved or who were involved in the error. At-risk behavior, you have to coach. For reckless behavior, you have to punish. Okay. Now, let's go through some scenarios. In digoxin 10 microgram orally twice a day was prescribed for a pediatric patient. The pharmacist mistakenly, while verifying the odd, typed 2 milliliter, equivalent to 100 microgram instead of 0.2 milliliter. No harm to the patient, but with the potential to cause digoxin toxicity. Now, no harm to the patient, but with the potential to cause digoxin toxicity. What could it be? Human error, or at-risk behavior, or reckless behavior? If I get perfect answers, so we'll end up the just culture and we will go to the risk assessment.
So the chat box is saying human error.
Of course, it's a human error. And what we have to do? To console. Okay. The last one, let me just do. Okay. Scenario 4, a surgeon drops an instrument on the floor in the operating room. Upset by the delay, the surgeon reaches down to the floor, picks up the dropped instrument, and then continues with the surgery using that same instrument. The scrub nurse looks at the surgeon, horrified by the significant breach in the sterile procedure. What kind of breach is this? Human error, or it is at-risk behavior, or reckless behavior?
I think it would be an at-risk behavior because here he is consciously, subconsciously justifying his actions on the account of the delay in the surgery.
Okay, but let's say that nothing, if you're doing something and you don't have enough time to do it safely, so it is said that you shouldn't do it. And he is in operation theater. If, for example, you are preparing oral syrups, that is oral compounding, you're preparing a syrup for oral administration, and on the next, you are preparing chemo, and you have the same thing, something drops and then you pick it up and then you continue. So do you think the risk is same in both areas?
No, so that would not be same.
Of course, the behavior is the same, but the risk is not the same. You cannot justify that risk. He is in OT. So nothing can justify such risk because he will end up with an SSI, surgical site infection. So this is what reckless behavior, and he should be punished. Okay, so think of a just culture. It is just you teaching your kids. It is more of what we teach our kids, an expectation that errors will be reported. and transparency. What we want to hear from the kids, that they should be transparent to us. Whatever mistakes they do, so they report to us. No expectation of perfection. We should not expect that perfection from them. They will do, they will commit mistakes. They will do it. Accountability for choosing to take risks and expectations set at system level. So this is how we can think about a just culture that we teaching our kid in a home. So this is how we can relate a just culture with. Okay, then last is when a second victim, when the errors happen, so there is a second victim as well. And you have to talk to the second victim, you have to take care about the second victim, not only about the errors that happen. So always, whenever there is an error, please try to approach the one who was behind the error, because he or she will be a second victim. And the IHI, they have reported a white paper on psychological safety, because whoever commit an error, they of course they feel guilty of it, and if it harmed the patient, so of course they will feel much guilt. So you have to approach the staff, because some people, they are very sensitive. They may commit suicide because of the error that they do. Maybe the patient dies because of an error, or maybe they leave the job because of the error that's been done. So because they are sensitive to either the patient's safety or to their reputation, so you have to talk to the second victim always. So the choice is yours, the choice is ours, whether we want to be doves or hawks, who we are. This is about our first session. We will be moving to risk management. And if I can have 2 minutes just to drink water, you can have also your water, and just within 2 minutes, we will be back to the risk management, unless we have a question here.
Sure, sir. I do have a question, if it's okay with you.
Sure.
So I was thinking, with respect to the psychology of the human mind, we know that each human mind is unique in its own way, and each human mind approaches a question that is presented to it in a separate way. Matlab, if you're presented with a question, it's not necessary for all of us, yeah, for all of the participants to think about that question in a same particular way, right? So complementing that part into the equation where we get data about the culture of a hospital. So how do you, as a CPHQ professional, disqualify those responses that might be because of how the staff that took those questions think about them? For example, when we were talking about it, you said a slide where you said that there was a question that will the errors that we make be held against ourselves? Yeah, does the staff think that their errors are not being written up, their names are being written up, right?
Okay.
So how would you justify, how would you disqualify those answers that are being given in the sense of prejudice against them? जैसे कुछ लोग होते हैं, उनके सोचने का तरीका ऐसा होता है, they like to think that they are being prosecuted by someone on their errors rather than being thinking about being consoled.
So see, if I get your question well, when we're talking about measuring the culture, so you cannot measure somebody's perceptions while others not. So whenever you're measuring the culture, you have to measure across the organization. You cannot be selective enough. You cannot say that, no, because these people are negative always, so I will not measure them because I know their response. But others, like nursing, I will say that they remain positive, so I will measure them so to have a better approach or a better display of results. So this is not where we have to end up. What we have to do, of course, we have to measure the culture across the organization to know the perceptions of people, to know the perception of the staff across in different organizations throughout, whether they are in management, whether they are clinical staff, whether they are medical staff, whether they are ancillary departments, whoever they are. So we have to measure throughout, and this is what we have to know, that we as an organization, we stand up, not as an individual. For example, now the beauty of this survey is that you can do it on a unit base. Once you use the SurveyMonkey process, so you can measure the culture on unit wise, you can measure the culture through organization. So once you do it through hospital wide, you can then see in the nursing department separate, you can see in pharmacy department separate, you can see in medical separate. So there you can see also that why to a particular question, the nursing department, their compliance or their positivity rate is lower than pharmacists or the paramedics. So this will tell you that something wrong, maybe in their management, maybe in their administration, or maybe the organization or the leadership behavior with them, maybe they're selective. So you have to, the bottom line is, you have to measure culture across the organization, not in a unit. You cannot do it in solos. Okay, and this is the beauty that we have to know from every single staff what they perceive. If you see one picture, that the elephant picture that I put there, so there were perceptions. Everybody is saying that it was in a books, I think, believe that in KGB studied that some kids are saying when they're touching the ears of the elephant that it is a fan. Some others are saying something else. So this is how they perceive the organization culture, and this is how we measure and manage.
Excellent, so it's quite clear now. So I think we should start with the next presentation now.
Let me, if you can help me just to, are you a co-host? If you can just share the next slides.
Because sure, I'll share the next slides.
Let me try to go to, thank you. Can we move on? Okay, so at the completion of this activity, you will be able to describe risk versus hazards, type of risk and hazards, risk mapping, risk register, and risk management process, steps, and FEMIA. One of the example that how we do assess the risk, so that is we will display a FEMIA. Risk is what? Likelihood or chance that risk will happen if exposed to hazard. And then we categorize the risk into acceptable and unacceptable risk. Acceptable risk we can define good is judged to be greater than potential harm. Like for example, chemotherapy, when we are giving to a patient, so of course there is a risk to the patient. Amputation or any surgical intervention, when we're doing any surgical intervention or if we're doing operation, so there is a risk of physical harm to the patient, but still it is needed, it is warranted. So we judge the potential good, when we judge the potential good is greater than potential harm, so we are saying this is acceptable risk. Number two, if the skill level is judged appropriate for an activity. For example, rock climbing. If you have seen climbers, so they're climbing the rocks. And if you see them, so it looks like what they're doing is quite risky. But what are they doing? Aviation. Anybody can fly a jet? Of course not. Surgical intervention. Anybody can go without training and skill level, their perfect skill level to do surgeries? Of course not. Why they can do it? Even out of among us, maybe there are many who can do, who are expert in sterile compounding. Me, I may not be able to do it because I didn't practice it. So skill level has to be judged. If it is appropriate for an activity, we say that the risk behind the activity is an acceptable risk. So you have to look for two things. The potential good is greater than potential harm. And the second thing is the skill level of the doer, of an employee, is relevant to, or it meets the criteria for the intervention that he is going to conduct or undertake. Number two is unacceptable risk. Here is the vice versa. The potential benefit or the potential harm is judged to be greater than potential good, or the potential good is less than potential harm. Like, for example, giving antibiotic for a non-viral infection. And pharmacists always, they fight for it with the physician. Patient is having a viral infection, why you are going to prescribe an antibiotic? Because antibiotic will harm the patient. So the benefit, antibiotic is not going to cure viral infection, so it will just harm. That's why we're saying that the harm is judged to be is greater than a potential good. Another is surgical intervention, while conservative therapy is an option. If there is an option to go with conservative therapy, why should a surgeon do an amputation? The next could be like choosing not to use standard vaccination, like especially nowadays during COVID, that the infection control practitioners, they're informing us that to vaccinate yourself. But if we're not vaccinating ourselves, so of course there is a risk, and that is not justified. So this is unacceptable risk. Now the goal is do more good than harm. Do not harm the patient. And this came since centuries, that the patient safety, what we say, they treat the patient without harm, or do not harm the patient. And the risk versus benefit assessment, then patient caregiver must be involved with the judgment. This is the goal of risk assessment. Okay. We talk about in the risk definition about hazard. So what hazard is actually? A hazard is nothing. It is a source of potential harm. Examples like surgery. Surgery itself is a hazard. Medication administration, the process of medication administration is itself a hazard, especially IV medication. This may harm the patient. This may put vulnerable the patient to develop an infection. So this is what the process itself is a hazard. The possibility of getting the harm, this is what we call risk, parental lines. So these all are the sources of potential harm, and this is what we call hazards. Next, please. Okay, now types of risk: patient care related risk, medical staff related, employee related, property related, organizational, claims, communication, and IT, financial, and others. So there are several types of risk in any organization. In a healthcare, we divide it into 7 and 8, and we are not going to go in detail of each risk, but these are the different type of risks that may reside in any organization. Next, please. Okay, let's go to the poll. How does an organization transfer the consequences of a risk to another organization? The question is transferring the consequences of risk to another organization. Options: design change, warning labels, acceptance, purchase insurance. I can see from, okay, culture. We will go in a bit hurry because we don't have that much time. So we need to cover up. And I cannot see the poll yet. Warning labels, purchase insurance. See, the question, as I repeat again, how does an organization transfer the consequences? So the word, you will have such questions in exam. There will be some keywords like transferring the consequences of risk. How you will transfer? Of course, by purchasing insurance. If you have a car and you purchasing insurance, why? Because you want to transfer the consequences of the risk. With design change, if you change the design of your car, will it help? Of course not. If you put in some warning labels that please keep away, keep a distance, will it help? Of course not. It may help in some that people may not drive near to you or behind you, but it will not transfer the risk from you. It is not going to transfer the consequences. So the only way to transfer the consequences, you have to purchase insurance. Next, please. What is a key hurdle to overcome when implementing risk management techniques? That's a spelling mistake, risk management, RM. So what is a key hurdle to overcome when implementing risk management techniques? Additional headcount for added responsibility, a return on investment, written procedures for risk management, top management support. Oh, good. 100% are saying top management support, but it's 1 out of 1. So of course, without top management support, you cannot get staff buy-in. So the best answer is that you have to, anything you have to do, whether it's quality and patient safety activities or risk management activities, when you are implementing, if your leadership is not with you, or if what you're doing, it is not aligned with strategic objectives. So of course, we are not going to end up somewhere you want. What's important is you have to have management support. Next, please. Okay, a national clothing catalog company wants, the question becomes a little bit complicated. A national clothing catalog company wants to evaluate the potential customer service and deliver risk of a centralized distribution hub, which will be the best problem-solving tool to analyze potential risk. There are keywords: potential customer service and risk. PDCA or PDSA is never used here. It is a process improvement methodology. And the best methodology that you have to use over here is FEMA, failure mode and effect analysis. Next, please. If there are multiple questions, so we can end up and we can go further after this question. To have a successful quality improvement process, a risk management program must have which of the following? An autocratic management style, interactive multidisciplinary team, mindset that most problems are caused by processes, full support of senior management, and then 1, 2, 3, 2, 3, 4, 1, 2, 4, 1, 3, 4. I think the poll question, there was problem in generating the poll, I believe, Saad, because the answers should be from A, B, C, D, not from 1, 2, 3, 4. 3 and 4, of course, style, you are not going to achieve anything. So once your risk management program and you want it to be successful, so what you have to do, you have to do it through multidisciplinary teams. And of course, a mindset that most problems are caused by processes, by system, not by humans. Full support of senior management. So these 3 are the options, 2, 3, and 4. Okay, there are further questions, so please skip and we can go. Okay. Now, we talk about risk, we talk about hazards. Now, risk management is what? Ye kya wala hai? So risk management is organizational effort to identify and assess the risk and then developing strategies to manage the risk. Simple. You have to identify the risk and then to plan strategies, then develop strategies to manage those risks. So how you can do it? Organizational risk may range, as you know, maybe there will be minor disruptions or major catastrophes, and it could be a minor risk or a major risk. Identifying potential risk can be a challenging. Of course, this is not an easy task to identify the risk, but we have to use some tools to identify the risk in an organization. Various tools that should be used to accomplish this task. And then Risk control and mitigation can be done through either avoidance, mitigation, or transfer. So the first question was like contractual transfer, that you have the consequences of the risk through what? Insurance. So either you can avoid the risk. If you can eliminate the risk completely, so this is what we call avoidance. If you cannot eliminate it, if you cannot avoid something, mitigate it. The